Bueno, buenos días para todos. Mi nombre es Julián Barahona. Yo soy el antiguo jefe de residentes del Departamento de Medicina Interna de la Universidad Javeriana. Hoy voy a hacer parte de la moderación de la presentación del profesor invitado que tenemos hoy. Hoy tenemos pues un profesor invitado muy especial que les voy a presentar. La doctora Cañas se excusa porque en este momento tiene una reunión en simultánea y pues por eso estoy yo como representante. Hoy nos acompañan dos grandes expositoras, una es la doctora Anja Krumaj. La doctora Anja Krumaj es directora del programa de salud global de la Universidad de Maastricht en Países Bajos, es docente del Departamento de Salud, Ética y Sociedad de la Universidad de Maastricht en Países Bajos y también es docente del Departamento de Salud Pública en las universidades de Manipal y Thammasat en Tailandia y adicionalmente de la Universidad McMaster en Canadá. Por otro lado, la doctora Yasmín Cadena es una de nuestras docentes aquí en la universidad. Ella es médica cirujana de la Pontificia Universidad Javeriana, doctora en Salud Global y Antropología de la Salud de la Salud de la Universidad de Maastricht en los Países Bajos y además es magíster en Salud Pública de la Universidad Hebrea de Jerusalén, Israel. Actualmente se desempeña como docente de la Pontificia Universidad Javeriana en la Facultad de Medicina y del Departamento de Medicina Preventiva y Social. Entonces, pues sin más preámbulos, daré inicio a la conferencia. Dr. Krumaj, be our guest. Thank you for accepting our invitation. It's really a great pleasure to have you with us in our guest professor lecture. This is like a kind of a research ground in our university. So it's a great pleasure for us. Thank you so much.
Okay.
And Dr. Cadena, it's a great pleasure for you to be with us and to help you to have Dr. Krumaj as our lecturer today.
Okay, thank you very much for your kind introduction. I do not speak Spanish very well, but I can understand more or less what you're saying. I agree with it. So what I would like to discuss with you today is what we in Maastricht have developed over the last 12 years, what we think is global health is about and what research should be focusing on. And I have done this lecture some years ago also in Havriana, but I added and changed a little bit according to discussions that we have with our current and our previous batch of global health students, who are students from all over the world and bring their own needs and ideas about what global health should be. So we try to always be in a dialogue with our students, and so we are continuously adjusting our programs and our research focus. So I think that the whole idea of global health is started with the awareness that globalization takes us a larger and larger place, is becoming more and more important in our lives all over the world. Globalization in the 21st century involves the movement of and flows across borders of people and professionals and goods and money and technologies and ideas and concepts and practices with increased possibilities to travel and of course also IT and online technologies. This goes faster and faster, this exchange in all kind of ways. It is not a new idea. It dates back a long time ago, before colonialism, but in colonialism it gained speed, and since colonial times, although we are no longer formally recognizing the whole concept of colonies, we could say that the world as it is organized today has still all kind of power hierarchies in it, and are mostly reflected in world market economy and which has a really a neoliberalist nature, and in the way we look for technological solutions to all kind of problems, including health problems. If you look at how this is organized across the globe, and how you see neoliberalist ideas in ways in which we collaborate. You see an increase over the last decades in public and private partnerships, where public bodies, universities, governmental bodies, and private companies collaborate together, try to find research grant, try to find money for developing and designing innovations. And so a lot of public money ends up in partnerships that are also partly private. And I think the AstraZeneca example, where Oxford collaborates with a Swedish company, is a very, how do you say that, clear example of that. There's also product development partnerships, again, in a similar way. And you see an increase also in philanthrocapitalism, where people like Bill Gates and others who have a lot of money try to become a player in the field of global health. So as I said, it's not new, but it's not a new concept, this international connectedness and global connectedness, but it's speeding up. And although we got rid of formal forms of colonialism, this is very often still on very unequal terms, and it's still impacting local life. It's impacting local life everywhere across the globe, but not everywhere in the same way. And if you study it more closely, you see that these new forms of globalization have an impact on inequalities, and in some cases increase inequalities rather than decrease them. These globalization trends are connected to overheating economies. We see climate change, we see border conflicts, we see all kinds of problems occurring that are no longer confined to particular states, but go across the borders. We see new attempts to govern these kind of cross-border problems. We see new forms of governance, we see new ways of trying to at least collaborate, and in the whole development we see a changing role of the nation state and the responsibilities of national governments. New inequalities materialize, and if we look at them a little bit closer, we see that the impact of globalization impact everybody, has an effect on everybody, but it depends very much on where one lives, how our lives change due to globalization. So as I said, it changes lives everywhere, but not in the same positive or negative way for everybody. So looking at these historical changes and trends in globalization, if you look at global health in this context, you will realize that global health and the study of global health entails a lot of different kind of things. So global health is, for instance, understanding about how global and regional economies and geopolitical trends, how they impact life and health of individuals and communities across the globe. So it is also about understanding the transnational dimensions of health risk and disease. So people living in a particular location in, let's say, Colombia or in the Netherlands, their health risks and their diseases are shaped by all these transnational processes and dimensions. So global health is actually about trying to understand how this works and how these processes and trends lead to increasing and also new health inequalities within countries, but also between countries. Global health is therefore also about finding and creating new ways and experimenting and looking at how can we govern all this, how can we make it transparent and more democratic, how do we give everybody a place and everybody a voice, and how do we need to change the role of national governments and international players in the field. So, having said this, I would say that research and studies on global health have actually 5 different dimensions and 5 different foci that are interconnected, but I would like to discuss all 5 here shortly with you. The first one is of course, and COVID is, and the corona pandemic is an example here. We are facing transnational crisis and the impact on the health of the world population. We face pandemics that are not concerned about passports and crossing borders. They go wherever they want. We see humanitarian crisis, and we also see that the impact of these transnational crises impact vulnerable groups of people in particular. And we also see that the way we shape and organize humanitarian aid also impacts populations in different ways. Sometimes it is for the better, sometimes it increases inequalities. And the study of global health and the studies in global health should be about how do we handle this? How can we organize surveillance, warning systems, data banks, information? How can we collaborate? Who will be responsible, etc. And this leads to the second dimension that we need to focus our research on in the field of global health. And that is the transnational governance of problems in the context of current geopolitics and trade. So we need to wonder, to identify who are the players in this transnational field of global health. Who are involved? Governments, international companies, and international organizations, WHO, Global Fund, what kind of philanthrocapitalistic organizations? Who are they and what are they doing? What are their tasks and how do they interplay and how do they influence and try to shape the field and get their way? Linked to that is which of these players has the power to define exactly what the problem is. We can define problems in many ways. We can define a problem as an individual behavioral problem, like when we look at malaria, we can see it as a problem of people not using prophylaxis or not using impregnated bed nets. But we can also look at malaria as a problem of mosquitoes. We can also look at malaria as a problem of inequality and poverty. And it's important to see which the players are, what kind of people are involved in the global arena and who has the power to define malaria. And you see that often malaria is framed in terms of individual behavior, which keeps business interests out of the picture. So who defines the problem? Who sets the agenda? Who determines the starting points of research? Who determines what we focus on? Who determines who gets blamed? Is it international relationships leading to poverty, or is it individuals who behave in an unhealthy way? Who claims responsibility? Who says, well, I can fix the problem, let me do it? And what is the impact of all these interplays and these political plays and power plays on what's happening in the global arena and what's happening with a particular problem, for instance, such as malaria? And the question that relates to the previous one, how to govern that, how to lead that in all kind of transparent and democratic channels, how to do that, how to make sure everybody gets heard, everybody gets their share and that it's not particular dominant players who set the agenda, define the problems. If you look at, I'll give you some small problems for examples here. If you look at the European Union's policy regarding to human resources, you see that their policy is based on the principles of free market forces of supply and demand. And because they keep applying and implementing these kind of policies, you see that this leads to brain drain in other countries. You see a very important recent example is the vaccine distribution. How is this organized? Who is playing? Who is deciding? Who has a say? Who says, who determines what the problem of the distribution is and what needs to be addressed? If you look at Ebola, also again in the European Union is seen as a problem of securitization, and policies are mostly about how do we keep Europe safe rather than how can we tackle Ebola in the countries where it is creating havoc. As I said, malaria already as a behavioral problem rather than a problem of inequality or limited access to good housing or safe environments. Prices of drugs, patents, another one. By calling diseases, some of the diseases tropical, you kind of imply that they are diseases that take place far away from, for instance, countries in Europe. And because they are far away, we are not so interested in fixing them. And in terms of research and grant money, they are being neglected. So these are all kind of problems that relate to how can we govern this enormous field and how can we make it fair, and how can we organize this in a transparent and truly democratic and equal way. It's another field, policy-oriented field in global health. The third field that we need to really look into, I think, if we look at global health, is focusing on how local situations and local contexts and settings are being shaped by historical and international processes. We often tend to look at local culture and local social and economic organizations and studying them as isolated local cultures. But what we often forget is that these situations and these cultures and economic and social structures have not always been there, are not traditionally there, but have also been shaped by historical and international power plays and historical processes. And I'll try to illustrate this with an example from Dominica, not the Dominican Republic, but Dominica, a small island in the Caribbean that was a former British, sometimes French colony, became independent in 1978. It has a native indigenous population, but it also, the majority of the people are the descendants of slaves that have been transported to Dominica some centuries ago. If you look at the Dominican situation, you see that the economy in Dominica is actually divided in two types or two economies, and the one is run by the man, and one is run by the women. And both genders are in need of land for agricultural practice. So there's a male-female conflict about who can use the land. And these male-female, these gender relations, they underlie the division of labor. So if you look at what men do, men are involved since some years in the production of bananas and biological produced fruits for the export to, for instance, the UK, and it is organized and almost fully dominated by UK company Geest, that subsidizes and organizes the production of bananas and biological fruit. It determines the quality, it determines how things are being produced, it provides farmers with pesticides and technology and capital, and it also guarantees a particular price for the bananas. But since it is an exercise or an endeavor that was initiated by a European company, it's focused on men, because in Europe we cannot think of farmers as being female. In Europe, farmers are always men. So, and that's interesting because in Dominica originally, before Geest came, women were the ones who used the land for the production of vegetables, and they grew vegetables and fruits, and they had a network of trade across the different islands. So women were what they call in Dominica huckstering. They were hucksters, and they traveled with boats and across the different islands and provided all the islands with vegetables for local and regional use. And these women earned the income for their families, and they needed the land for that. After the introduction of the bananas by Geest, this conflict started to become very prominent. Women had to give up their land to the men who wanted to use it for the bananas. And Old British law was in favor of men. In Old British law from centuries ago, land was inherited and passed on in the male line. The male economy is the economy that is being documented, that is being the major focus of Dominican economic policy, and policies are always developed in favor of the banana and the fruit production, and the vegetable production by the women is completely ignored. And you can see how this division in male and female economy is the result of European interference via Geest. But you also see that the whole traditional way of doing things dates back to the times of slavery, where female-headed households became very important. Male slaves, Dominica was a slave depot, and so slaves that came in from Africa into Dominica, they were all mostly ended up in Dominica, and from there on they stayed a little bit on the small plantations in Dominica, and then mostly the men were sold to other islands, to the US and so on. And so the females with their children, the women with their children, they became small core units, and they often stayed together. The women had to grow vegetables. That was the way it was done. The women didn't get any food from the owners, but they had to grow their own food in their spare time. They got a small plot of land. So you see how this female focus on vegetables dates back to colonial and times of slavery, and is also going hand in hand with traditional notions of how male and female bodies work. The male and female traditional notions of male and female anatomy also date back to European and African notions of male and female anatomy. And they make it, justifiable and understandable that women being patient, liking small, tiny works, can do things with their hands, are smart. So the anatomy and the characters of women, according to European and African notions, made them perfectly suitable for the growing of vegetables, while men were strong and big and less patient, and for them bananas became the typical product. So you see how all these things date back to slavery, European African notions of femininity and masculinity, how it dates back to old British law, and how all this affects the health of women in a different way than it affects the health of men in Dominica. It impacts their livelihoods, access to housing, access to food and clean water in relation to poverty and so on, access to healthcare, education, and the health and the schooling of their children. So because women are responsible for these things, it also, this conflict with the man also leads to a lot of extra stress. So you see how what's going on locally is not a matter of isolated small cultures with their own ways of doing, but how cultures became shaped and grew in interaction with colonial processes and international process and international interference. A fourth, so this is another focus of global health research, looking at the intersection of history, international relationships, and local situations and their impact on the health of the people. A fourth dimension that I think is interesting and important in the field of global health is the traveling of knowledge and technologies and professional practices that have been invented in one place on our globe to another. Innovative things, innovation practices include not just, real technologies like corona tests or point of care tests for tuberculosis or AIDS, but also policies, professional practice, technologies, interventions, scientific conventions, in evidence-based trials, standardizations, protocols, guidelines, standards of the WHO about how to organize childcare, checklists, paradigm discourses, ideologies, philosophies. They travel across the world from the place where they came into being, where they were designed, invented, were given birth, to another place. And the thing here is that with these innovations, you can norms and values are introduced in new places. An innovative practice is usually not neutral. You can see how any kind of innovation being invented in a particular part of the world represents the norms and values and the assumptions about how reality works from that particular place. I will give you a very simple example. I have a son who has a Dominican father, and his appearance is quite Caribbean. And one day he studied biomedicine in Maastricht University, and one day they were looking at how you figure out body mass, how you measure body mass index. And one way is an MRI scan to do so. So he, with a group of other students, they went to look at an MRI scan. The technician asked if there was somebody who would like to volunteer. My son said, yes, I want to volunteer. I will go into the scan and you can compute my body mass index. And then the technician asked him, yeah, but are you black or are you white or are you Hispanic? And my son answered, I'm half black and I'm half white. And then the technician said, yeah, that's a little bit an in-between color, so we make you Hispanic. So they put Hispanic in the machine, and a body mass index, came out. But the interesting thing is that this was a machine that was built and developed in the US, where Hispanic and black and white are very important social categories. And they are not in the Netherlands, so you can see we also have, of course, categories, but not black, white, and Hispanic. And so you can see how in these machines, notions of how the world is divided in black, white and Hispanic, or other norms, values, etc., are built in the innovations. And that also goes not only for technologies, but also for policies, for anything that we transport from one place of the earth to the other. And so this can lead to all kind of problems. So if you don't know about these kind of things, how do you use these MRI scans? What good are they doing? So the thing is that innovations are not neutral. They come with inbuilt norms, values and notions about reality. They come with inbuilt ideas about where solutions are and what solutions should look like. And they are all put in that innovation on at the site where it is invented and created. But when you introduce that to new differing context, all kind of things can happen. The example of the MRI scan in the Netherlands is maybe innocent, but a lot of technologies are not so innocent, and they bring their own. They require the context to adjust to the technology, but also to the technology to adjust to the setting, and that can create a whole lot of unknown, unforeseen effects. So there might be problems in taking up an alignment. It has to be the innovation itself needs to be adjusted, or the setting needs to be made ready for receiving the innovation. And we don't know exactly what it will do. We can't think that the ordinary outputs, the ordinary results that we would like this innovation to have will be unproblematically the same for all kind of contexts. And in all kind of things all kind of instances can do harm rather than help. So these 4 dimensions, I think, are very important in the study of global health and globalization processes, because I think, to my experience, they impact health in everyday local life, blending in with local conditions, where practices and structures and norms and gender have become strongly interconnected, and into these complex settings you bring in new elements without knowing what that will do. There will be arranging and rearranging of all these elements without us having a clear idea in advance what the outcome will be, whether it might lead to new inequalities. And also what we need to keep in mind is that each setting across the globe has its own unique constellations of practice, structures, culture, gender. And so bringing in an innovation in, let's say, Colombia will maybe have completely different impact than when you do that in Africa or the Netherlands. And we need to keep constantly monitoring that when we try to change something for the better. And when we try to introduce an innovation that we keep an eye on what it's actually doing, unforeseen and maybe harmful side effects. So that means that global health problems are wicked and need transdisciplinary attention. We need historical analysis, cultural analysis. We need to look at economy. We need to look at health systems, social organization, because they are impacted, they are intersected in unique ways everywhere across the world. And when change takes place, they change in a unique way across different settings. Global health, as far as I see it, is about a critical gaze. We need to understand all these mechanisms that I have talked about. We need to understand how we can not only look for solutions, but also how we governance, how we make decisions, who will have responsibility, whose problems will be prioritized, what problems will be prioritized, how we frame them, that we do this in a fair, transparent and equal way. We need insight in underlying assumptions of innovations and projects and policies. And we need to really also look at the role of global health itself, and us as professionals ourselves, how are we involved and how we impact the field. So we aim to make things better, but we have to constantly keep an eye open to do no harm or no new harm or more harm. And a fifth dimension, and I was already saying, we have a constant dialogue with our students. We have students from all over the world, and in the previous years they said, well, global health should also be about addressing what they call coloniality, or what is called coloniality. And if you look at the knowledge in the global health field itself, and if you look at all the global health programs and what they focus on and how they frame problems, we also need to see what kind of norms, values, views on reality in the knowledge about global health itself are dominant. Whose norms, values, views on reality, whose are dominant. And very often, if you look at the field of global health, it's again colonialized or hijacked by universities in Europe, the United States. And they prioritize maybe what should be looked at within global health. They determine how global health problems are framed. And so we need to see how in global health we talk about geopolitics, about history, about political economy, and about global health policy, innovation and practice. So it's not just about not only about looking at how health problems come to be and the power plays and the hierarchies and the inequalities in there, but also who colonializes the field of global health itself and what we make it to be, and who is benefiting and who is determining the core concepts and the core problems, and what kind of plays are at the background of that. Our students are currently analyzing our own program to see what kind of language we use. They are looking at things like, do we often mention global north and global south? They try to unmask them as old typical European ways of dividing the world in a north and a south, or in developed or underdeveloped. And already the term tropical disease, by calling something a tropical disease, you make it a disease in a particular exoticized part of the world, and that has impact for priorities and research agendas. By calling something climate change, we make it into something neutral, natural, which lets people off the hook in terms of being responsible. We need to look at notions of body and health that are dominant in global health. The division between mind and body, for instance, which is dominant in many parts of the world, but not everywhere. And we, in the way we practice global health, these kind of dualisms, north-south, underdeveloped, developed, mind-body, these dualisms are kind of imposed on all parts of the world and form our knowledge, and that has an impact that makes a particular worldview dominant. The focus on economic development as a core value might be something that we need to look at. Practices such as scientific conventions is an interesting field. In the way we now organize science and impact factors and evidence-based with the priority of randomized clinical trials being, at the top of the hierarchy, very often leads to a lot of insights and information that is being collected unseen, and only the those who can do the big trials have the power, the scientific power, and can claim scientific superiority. If you look at how we discuss, for instance, the situation in particular countries like Iran or North Korea, and you look at how the situation is depicted also in scientific articles, you see that these articles are almost always written from a US or a European angle. And in these practices, some voices and some ways of looking are silenced, and others are, dominant and brought to the fore. So the fifth field of global health is a critical look at itself, its language, its concepts, and its practices. So to kind of conclude, global health is about going beyond the social determinants of health. It's not about a set of isolated determinants, but about understanding ill health and health risk as a result of of social, cultural, historical, economic, and political determination. But it might also be about unmasking and addressing coloniality in dominant disciplines, principles, and practices and languages that we nowadays use in public and global health. And I think that is my short introduction for you, my ideas on what in Maastricht at least we think global health should be about. So thank you for listening.
Thank you, Dr. Krumach. It was a great lecture. It was very enlightening for us. We as clinicians, we are mostly clinician-based, so we are not that aware of this kind of let's say, disciplines, because we are always in here in the hospital. So maybe we don't realize about the importance of these issues. I will give the word to Dr. Cadena. Please, Dr. Cadena, be my guest.
Thank you very much. Thank you very much, Anya, for your time and for this sharing with us about global health. And also thank you very much to Julian and the Department of Internal Medicine. I think we have a lot of things in common. I know that, as Julian say, you mostly of the time are at the hospital and with patients, but of course we also have many topics in common. So, for example, about the pandemic, we know that you are the people who are facing in the first line the COVID-19 pandemic as physicians, as medical practitioners, but we also have a lot of other topics in common, as Anya said, for example, regarding tropical diseases, as we mentioned, or climate change. So we have, I think, a lot of many topics in common that we can share, and also in terms of research. So nowadays we are building, with the help of Anya, the program of global health, our master program in global health, that will be in we will be part of a team of other universities with Norway, Nepal, Canada. So you are very welcome to join us. And also we have a group of research that is global health semillero. I'm not sure the word in English, semillero de salud global. So you are very welcome to join us in order to do some research together. So thank you very much for this opportunity, Julian. I'm not sure if there's someone who would like to or that have questions to Anya.
Yeah, actually, we have some questions for Dr. Krumach and for Dr. Cadena. Please, anyone who wants to make anything, you can write it. You can raise your hand. Till then, I will make the first question for Dr. Krumach and for Dr. Cadena. I think it's very important. The first question is, should we promote a culture of transdisciplinarity among clinicians in training? What do you think about this important issue?
Yes. For several reasons, but it depends also a little bit, of course, on what kind of physician you want to be. But I think if you take, for instance, the example of the corona vaccine, you are confronted directly with the success and the failure of the distribution of the vaccine. Depending on how successful it is, you will have a lot of patients in your hospital or less. And there's a lot of politics and issues involved in how are these vaccines developed, who have the ownership, who determine how they are being distributed. But also, I think in Corona you see that very importantly is that people, ordinary people like myself and my kids and you and your families, we also are affected by international, by newspapers, but also by feelings of our feelings about ourselves and each other. And you see in the context of Corona, in the beginning, we saw across the world a distrust against Chinese people, with Donald Trump calling it the China virus. But you see within the country and between countries an increased distrust and an increased nationalism and an increased protection. And I think that a lot of doctors across the world are involved in politics and involved in fighting the epidemic, but not only in the hospitals, but also advising. And I think these kind of issues are very important to know for people who need to advise governments. So it's not only the virological or the epidemiological knowledge that we need, but also these kind of political and social knowledges that we need to really find an effective way of distributing, for instance, a corona vaccine. We need to know how are they developed, who is buying them, how are they distributed, who's been involved. You know, a corona vaccine is a public-private partnership, but with a lot of patents. But it's also feeding into nationalist feelings in the Netherlands. People of the right populist parties are very distrustful. Also people in Africa for other reasons. And this all impacts the effectivity and the safety of these vaccines. So it's on all kind of levels. And I think doctors being involved in advising patients, but also in advising governments, may need to be aware.
Thank you, Dr. Krumach. I do agree with all your argument. Maybe Dr. Cadena wants to give an opinion about this?
I agree with Anya, absolutely. Okay. And also, I think in the daily life, you as doctor, I know you also know that very well, is to be aware of the condition of the patient in like a wall, in the context, and how all the decisions that are globally, of course, will affect our patients that are in front of us. So is to be aware that we are, in a world with many decisions, in a context with economics and politics around migration and many things that we need to be aware of it. Yeah,
that's true. Okay, we have another question in the chat. This question is made by Dr. Garcia. Dr. Garcia is one of our internal medicine professors, and he is quite interested in climate change and these kind of issues. So he says to us, thanks Dr. Anja for this interesting and inspirational way of introducing us as clinicians to global health topics. And the question is, how have you and your working group addressed the climate and health educational issues with your students? What would be your advice to implement this subject in undergraduate medical students?
We do address it all the time, actually. We try to include issues of climate change, but also other environmental issues in these kind of analysis and globalization processes, of course. By calling something climate change, we make it into a natural phenomena, which means that you don't have responsibility. It's something that happens in nature. And then you see how, okay, but now we need to do something, and it is the countries that have never benefited from all these, from technologies and industrializations, or have less benefited, are now having to clear up the problems, become responsible. And that leads to international tension. But also on a much smaller local level, if you look at, for instance, the problem of biodiversity. Chemicals, industrialization, pollution has led to decreased biodiversity. And decreased biodiversity in many cases has, messed up ecological balances. Which means that, for instance, in many places where biodiversity is decreased, you see an increase of mosquitoes, ticks, insects, and introduction of new diseases. Climate change in the Netherlands, we have now insects and animals in our nature that we never had before and that we can't deal with. And of course, Corona itself is being linked to ecological pressure and of people not having enough food and going for bats and other animals that maybe have brought Corona. So we try to show our students, also our medical students, we have half of our students is medical students, how medical problems are absolutely linked to issues of climate, environment, biodiversity, etc. And that you need to tackle issues of livelihood and poverty at the same time as tackling issues of biodiversity and greening. And again, maybe when you have a patient in front of you in the hospital, first you need to, provide that patient with urgent care. But at the same time, when you are outside the hospital, it's good that you have these kind of insights and can maybe become an activist.
Okay, Dr. Krumai. Thank you so much. Dr. Kayana, maybe you want to do any comment about this issue?
Yes, we, maybe I don't know if you are aware of it as well, but we are also working as a university with the Estudios Rurales y Ambientales department here at Javeriana, and they are also trying to include these topics during the whole careers. So we as medicine have different lectures as well, and it's more from the perspective of educational health, but just to be conscious about this topic also with our students and in our daily life here at the university.
Okay, thank you, Dr. Cadena. De pronto, ¿hay alguien más que quiera hacer preguntas? Creo que Sebas tenía la mano levantada ahorita. No sé si Sebas quiera hacer su pregunta.
Good morning, I'm Sebastian, internal medicine resident. Thank you for your amazing talk. I wanted to ask you, how do you think we could improve the access to training in innovation for working clinicians in middle-income countries such as ours?
I'm not entirely sure I got your question entirely, because the audio was not entirely good. Do I understand correctly that you are asking how we can use or implement this kind of approaches in a middle-income country such as Colombia?
He's more like the question is more about like how to improve the access to training in innovation, because you talked about innovation and importance of innovation as a global health measure.
Yeah, well, we have included this whole topic of implementation and innovation in the Maastricht curriculum. students can take that for 12 weeks. Is, by the way, open for students from Colombia. So you can, students from Colombia or Rosario or Javeriana can come to Maastricht and take this course. And it's specifically designed to think about how to design, implement, evaluate all kind of innovations in a very critical and reflective way. So that would be one way, but of course that would be coming to Maastricht, which or following our courses, which in itself may be not according to the rules of the things that I've just been talking about. But it is possible to train people who are involved in the design of innovations, new technologies, etc. To make them aware and to give them research tools and research approaches and methodologies to study that. Also, of course, in Colombia. But it depends also on how the courses are designed. But it's not. The access is, of course, another problem. That's a more general problem. How many students can we train in Colombia, in the Netherlands, etc. But that's a problem that I'm afraid is a more general problem in all of our countries. So it's not the topic. It's more in general. To increase access. Yeah.
Yeah, that's like the one of the issues. Indeed. Dr. Hidalgo, who is the professor that is in charge of internationalization in our faculty, in our School of Medicine, says to you, thanks Dr. Krumai and Dr. Cadena for the excellent lecture and for being again with us. Let me tell you that we also hope our team and yours could continue to the collaborative work started by Dr. Jasmine. Why I think this is important, because I think that the example that you gave us, that you in your undergraduate let's say syllabus, you have this the innovation subject inside your syllabus, and I think that's very, very important and very impressive. So it's a great example for us. Maybe Dr. Cadena want to say something? And well, I will give. We have another question from Doctor. Ana Cecilia, adelante, puedes preguntar.
Gracias, Julián. Tú me dirás, ¿la hago en inglés, en español o no importa?
Como te sientas más cómoda.
Hello, Dr. Ania. Thank you for your speech. It was very good for us. I have a question for you. Do you think we should, the clinical should be more involved in the development of public policies?
Sure. Of course. I think to make effective policies, we need, of course, we need to know the medical, we have to have the medical, the epidemiological knowledge. But they intersect. It intersects with the social sciences and history. And what I think is that if you look at health, you need to understand everything from the molecular level to his colonial history to understand why a person falls ill. And that is one that will help you design policies, but you do also need medical knowledge as part of that. And I think doctors have a very good position to be listened to. So I think that is an important element in many countries. And I think health, technology, social, our social life, our political lives, we can't understand one without the other. And if you want to design new policies, new technologies, even simple technologies that could be used in your hospital, tools for diagnosis or medication or vaccines. If you know more about all these backgrounds, you will be a more effective doctor, not only in terms of being a political activist, but also in advising your patients, because you will understand where they came from and how easy or difficult it is for them to follow your advices. So I think it is important. Yeah.
Okay, thank you. It's one of
Thank you very much.
It's one of our great challenges to improve awareness and like sensibilization about this topic among clinicians. Maybe Dr. Cadena want to say any comment about this issue, or can I continue with another question?
Yes, please continue. Just to say that you are very welcome to work with us, just answering a little bit about the comment of Dr. Hidalgo. So you are very welcome. Thank you very much for invite us to share about global health, because it's something that involves all of us, as health workers, of course.
I got another question here.
Hi. So
Hello.
Thank you for your conference. Yeah. I wanted to ask you, because I really don't know if you have like some kind of program that involves school, like to generate the importance of these topics since really early stages of education. And if you think that is important, those kind of programs in our country, maybe, because I think this is better, like better targeted if we do it since primary school. I think maybe those like programs with Plaza Sésamo and stuff would have like more impact in public health than university PhDs and stuff.
Yeah, I think you have a point. These kind of awarenesses may not be only for doctors, and when I say doctors are in an excellent position to be listened to, that is good, because we have a group of people that other people may want to listen to, but it's also a bit sad that we need doctors to do that for us, and that we as a society are not able to come up with these kind of insights and awarenesses ourselves. And we don't have a program like this in high schools or for younger children. But actually, I agree with you. We should start to look into that. And I'm involved in a project with people in Bangladesh who is focusing on particularly that, starting with kids from 10 years onwards, to make them aware, to give them the skills to learn, to teach them how to act and how to formulate and vocalize and so on. But that is something that we're only just starting, and that is not in the Netherlands, that's in Bangladesh. So they are a little bit ahead of everybody, I think, maybe in that respect.
Okay, thank you, Kumail. That's a great news. Those are great news to know that there's something ongoing somewhere, because it's a great example. And the last question I have is from Dr. Valencia. Dr. Valencia is one of our internal medicine professors, and I think she's it's a great example of how to mingle public health and internal medicine. Her question is: thanks for your presentation, Dr. Anja. What is the global health program structure at the Maastricht University? How is it offered? Actually, she tells us that she is a public health master student and she's interested in getting involved in it. Maybe can you tell us about?
We have there's maybe several things that are interesting. We have a program in Maastricht, and that starts with this whole issue of governance that I covered. Who are the players? What are the possibilities to to organize that in a more democratic, transparent way, etc. Then we have a module where we, as I said, where we start to look at molecular level, go from there to genetics, epigenetics, social determination of health, to history and culture and colonial history. So we try to show students the whole range of dimensions that make people, that impact people's risk. But that is, and then we have 12 weeks where we can look at innovations, as I mentioned, but the program also is collaborating with partners across the world in India, Thailand, Sudan, Norway, Canada, and of course also in Colombia already. There we collaborate with universities from other parts of the world who each have their own vision on what global health should be. So what I was talking about today is what we do in Maastricht, but we do not want to claim to be the only ones who know what global health should be about. So students in Thailand get the Thai version of global health, and students in Sudan get the Sudanese version of global health that is kind of tailored to the questions and the needs of these countries and the vision of these countries on what is important. So the first part of the program, everybody teaches their own notion of global health. The second part, when we offer the innovation courses, that is a part when the students from all the different partners can cross over to each other and pick up electives and specializations from the other universities. So our innovations courses are open to the students of the other partners, and everybody can, without any extra tuition fee or whatever, follow each other's courses. At the same time, we also think that global health is about collaboration. So we have in the first trimester and in the second trimester courses that we call Foundations for Global Health, in which the students from all these partnering universities are working together on assignments. And in the first semester they have to critically analyze a global health policy according to all the points that I was giving. But the other universities teach other things, so the students have to find ways to collaborate and coordinate all kinds of different ideas on how you critically analyze a global health policy. And so, and these courses are designed and taught by the different partners. So in Maastricht we cover the things that I was telling you about, but we also open up to other partners and give a room for other views on what global health should be about. And we ask students to collaborate, bringing in different disciplines, different countries and languages and practices, but also bringing in different views on what global health should be about. And we think that's an important skill for these professionals to later design and act and become global health professionals.
Thank you, Dr. Krume. That's great to know these kind of programs are available for us. And well, maybe if Dr. Kana wants to say something else, or maybe we can thank Dr. Krume for her lecture.
Yes, just to say that we also are building our own program, our master program on global health. That is part, of course, of this partnership with the other universities, including Maastricht University. So there is the possibility also to travel and to see the different perspectives of the other universities in other contexts. So welcome also to join us in this construction of our own program from Javeriana. Yeah.
Thank you, Dr. Kaina. So thank you, Dr. Krume, for being with us. It was great. We hope to have you in our next opportunity. Dr. Kaina, it's a great pleasure to be working with you, and let's expect that we can do some more collaborative work in the near future. Aprovecho para hacer nuevamente la cuña del programa que está en desarrollo de Maestría de Salud Global en la Universidad Javeriana. Sabemos entonces que están conjunto con universidades de Noruega, Holanda y otras adicionales, y pues tenemos el semillero de investigación en salud global para todos los que estén interesados. Les agradezco mucho por su participación. y fue muy bueno pues tener este tipo de conversaciones tan transdisciplinarias para todos. Muchas gracias para todos, una feliz tarde.
Thank you very much, Julian. Thank you very much, Dr. Anya. See you next time. Thank you.
Thank you very much for listening, and success.
Thank you. Bye-bye.
Bye.